Assalamu alaikum. Hope everyone is doing well. So basically we have started an oncology class where me and my colleagues would share diagnosis and management plan of solid tumors and hematologic malignancies. It is just an effort to help our oncology residents to learn about insights of various cancers that can help them in future in their specialty exams. Now the first topic that I have chose is pancreatic cancer, and in the first class we will discuss the pancreatic cancer under these 4 points that I have already mentioned. First of all, we will discuss and talk about something regarding epidemiology. So pancreatic cancers are not very much common in our country. However, they are a very serious health problem. Pancreatic cancer is a very serious health problem in US. Approximately 56,000 cases are being diagnosed per year in US, and almost 45,000 patients die annually because of pancreatic cancer. When we talk about the 5-year survival rates, then the locally advanced disease has a survival rate of approximately 30%, whereas metastatic disease has a survival rate of less than 5%, and the survival rates that I have documented are basically 5-year survival rates. Now we will come towards the risk factors. As far as the risk factors are concerned, common risk factors that cause pancreatic cancer are obesity, alcohol, smoking, pre-malignant lesions, diet that is rich in saturated fats, some drugs that include insulin and sulfonyl ureas. So while talking about the pre-malignant lesions, the pre-malignant conditions in pancreatic cancer, there are basically 2 common pre-malignant lesions that we can see in pancreatic cancer. One is the mucinous cystic neoplasm, and the second one is intraductal papillary neoplasm. So now we will talk about the management plan of these mucinous cystic neoplasm and the intraductal papillary neoplasm. So when a mucinous cystic neoplasm is present, then resection should be done. As far as the intraductal papillary neoplasm is concerned, if it is involving the main duct, then resection should be done. Resection in all cases. However, if it is involving the branched duct, then we can go for surveillance plan. Okay, so now we will talk about the genetics of pancreatic cancer. So the germline mutations that are present in pancreatic cancer are BRCA1 and 2, ATM, PALB2, mutations related to the Lynch syndrome that include MSH 6, MLH1, MSH2, and those mutations. Furthermore, the important mutations include CDKN2A, then PRSS mutations, and STK11 mutations. STK11 mutation is the one that is present in the Peutz-Jeghers syndrome. PRSS mutations, these mutation patients usually present with a history of repeated episodes of chronic pancreatitis, and this is the one that is present in PJ syndrome. Okay, now we will talk about regarding the surveillance plan and how to look for these mutations and what to do. So first of all, there are two very important things that are very important regarding our FCPS part 2 exam. The most common mutation in pancreatic cancer is BRCA1 and 2. However, the mutations with highest penetrance are PRSS, CDKN2A, and STK11. Now, the highest penetrant gene in pancreatic cancer is PRSS, highest penetrance gene, then CDKN2A with a low penetrance as compared to PRSS, then STK11 gene with the lowest penetrance as compared to PRSS and CDKN2A. Now, how to do the genetic testing? First of all, there are three things. First of all patients that are diagnosed with pancreatic cancer should undergo genetic testing. Now, what this genetic testing is going to do, I will tell a little bit about this here, because the actual benefit of getting a genetic testing would be discussed in the treatment plan. So the benefit of genetic testing is that we can know regarding the various mutations like BRCA or PALB2, and there is role of PARP inhibitors maintenance in pancreatic cancer after completion of chemotherapy if the patient is BRCA or PALB2 mutant. This point we will discuss this point later on when we will discuss the treatment plan. So first testing should be done. First point is that all patients with pancreatic cancer should undergo genetic testing. Now, the second point is those patients who have a mutation of STK11, CDKN2A, or PRSS should undergo surveillance for the presence of any occult pancreatic cancer. As these patients I have already mentioned,